Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight we have our speaker, Dr. Roya Attar, who serves as Associate Professor and Director of Optometric Services at the University of Mississippi Medical Center in Jackson, Mississippi. A distinguished fellow of the American Academy of Optometry, she has assumed many pivotal roles, including chairing the AAO Retina Special Interest Group and serving as the Vice Chair of the AOA Leadership Development Committee. Additionally, she leads a local optometric society, actively contributing to discussions on best practices and professional advancement. She's been recognized with numerous awards, including Mississippi Young OD of the Year, SECO Young OD of the Year, AOA Young OD of the Year, and Women of Optometry Young OD of the Year. So it's really our great privilege and pleasure to bring Roya to you, our audience, to hear her expertise insight on retinal. So with that, Roya, please take it away.
Thank you so much. I appreciate that great introduction. Thank you everyone tonight for joining. And as we mentioned, our discussion today is on retina topics, talking about next generation retina care, looking at what we're doing now, what we're probably going to be doing in the future. And very importantly for all of us is how to work with retina specialists so that we take the best care of our patients. So I wanted to start out here with Dr. Dave Sackett, who is a pioneer of evidence-based medicine. And Dr. Sackett said half of what you learn in medical school, or in our case, optometry school, will either be dead wrong or out of date within 5 years after graduation. The kick is you don't know which half. So hence we always have these platforms to continue learning and growing. And more importantly, what true evidence-based practice is today is looking at what the data and the clinical trials and that information says, and also taking into consideration our own clinical practice and what we, how we treat our patients, what works for us clinically. So that is the true practice, I would say, of evidence-based medicine. So when we look at retinal conditions, there's a few conditions that we commonly see, and starting with macular degeneration. It affects over 11 million Americans. It's the leading cause of vision loss in adults ages 60 or older, and it's projected to grow substantially in the coming years. Treatments for it vary. The next one, a big one, certainly where I live here in Mississippi, is diabetic retinopathy. It affects 7.7 million Americans, and it's the leading cause of preventable blindness in working age adults. There's lots of different treatments for it and a whole slew of treatments that are in clinical trials. Other ones that you will see, not as common as the first two, will be retinal vein occlusions, and we're going to address those because treatments for those kind of mirror those of these other vascular conditions. And inherited retinal disorders. Now, those, although rare, for those patients that do suffer from these diseases, there's not a lot of things that we have been able to offer them as far as treatment. Whereas therapy-wise, we have been doing great, certainly low vision specialists and helping them to manage their vision loss, but there really hasn't been treatment, and that is all shifting as we are moving forward. A few other common retinal conditions, and I want you to consider all these as we move forward. One is looking at patients with atrophic and operculated retinal holes. This is not an uncommon thing that we see. Certainly one that we are able to see and diagnose even better with the advent of imaging and OCT technology. Same thing for lamellar and macular holes. Other things such as retinoschisis, and then importantly, retinal detachments, whether they be regamentogenous or tractional, and different treatments and how urgent each is depending on the circumstances per patient. So what are these treatment approaches that when you see a patient with coming into your clinic with any one of these conditions that you're going to speak to these patients about. Believe it or not, a lot of these treatments that patients are still receiving today, they're many, many, many years old, back from the 70s to the 90s. Many pivotal trials, such as the ETDRS and then the DRS studies that basically show PRP is good for someone with proliferative diabetic retinopathy and focal laser for clinically significant macular edema. Similar for BRVOs and CRVO studies, and then the photocoagulation study for CNVs back in the 80s. Clinical trials, if anything, they are getting much more vast, and there's like this alphabet soup of clinical trials if we wanted to look into them, and even more from the 90s to the 2000s and more today. I'm going to go in a little bit further in depth in clinical trials because it's really an area that I don't see a lot of our colleagues participating in, and that's something that we actually really need to shift and become more involved in these therapies, our potential future therapies for our patients. Just look at this list of novel agents that are being studied right now, just a plethora of clinical trials for everything from AMD, diabetic retinopathy, IRDs. And, if you are a pharmaceutical company, you want to target a disease like AMD or diabetic retinopathy because you'll know you have a large base of patients. Or you could, do something with the more rare diseases. They're a little bit easier to get FDA designation for fast track therapy because they're a lot considered orphan treatments, but a lot more difficult when recruiting patients for clinical trials. So speaking of talking about referring patients for clinical trials, before we jump into all the new therapies, I want to first talk about how we co-manage or really take care of our patients. And I use the word co-manage, but the truth is when we use that word co-manage, a lot of times we're really talking about our cataract patients. But I want you to sort of continue that same track of thought whenever you have these patients that you are referring for retinal conditions. So what are a few things that we may refer our patients for? Certainly any decrease in their vision, loss of vision, loss of distortion or flashes and floaters, because they could mean a whole host of things are going on. And this is not certainly a patient that we are going to hold on to, but many of these patients show up on our doorstep first. Why is that? Because somehow all the patients think that glasses will fix this. All right. It's probably just my glasses. So a lot of times we are the first ones seeing a lot of these issues. And when we see them, obviously, we have to deliver the news that no, glasses will not help you in this instance. We have to refer you to a specialist. And more importantly, we have to educate our patients. I can't stress this enough how important educating our patients is. Because I'm going to tell you what, if you have ever been to an office for a retina practice, first of all, your patients are lucky if they can get through being seen as fast as you see them, but there are a ton of patients there. So do you really think that the retina specialist is spending any time speaking to those patients? No, they are not. So it's very, very important. You already have that rapport with that patient. Educate patients about their retinal conditions, treatment options, and then very importantly about adhering to any prescribed therapies. In addition to that, for patients like, that have a lot of conditions that have a systemic factor contributing to their ocular presentation, you want to talk about lifestyle changes. I can't tell you how many times I've had a patient say, I've never had a doctor speak to me so much about this. I just thought I was coming to get glasses. I didn't know that you were going to be talking to me about my blood pressure or, how to monitor my blood sugar better. So very, very important because never ever assume that the other doctors are doing it. Uh, I always make this a practice. I always do it as if they are hearing it for the first time. So very, very important. A few other best practices for co-management, communication with your retina specialist. And notice what I said. I said with your retina specialist, because one of the things I have noticed that many of us do is, we'll actually say, well, I spoke to my retina specialist. And when I say speak, nobody really picks up the phone and calls. You should be able to essentially text a retina specialist. If you cannot, find one that you can, because that is probably one of the most convenient ways to sometimes communicate with them, if how fast they can see a patient, how urgent a case is, and just what they would recommend. So establishing that communication with a specialist, very, very important. Optometry and retina have one of the most symbiotic relationships in the eye care space. So having a retina specialist that you have that close relationship with is so valuable for you, for your patients, everything. And if you're lucky enough that your EHRs talk to each other, that's a really, really a wonderful thing in and of itself. Where I am currently at an academic medical center, we speak all the time within our EHR, and it is so nice because I can keep track of my patients and take a look at their images, the notes, all of those things. And these key clinical pearls are vital whenever you are referring a patient to a retina specialist. One of the very first things I tell a patient, very first thing is prepare them for their wait time. Because if they can get through a retina practice in 2 hours, that is phenomenal. If you know that your patient is not a very patient patient, you probably want to tell them get a very early appointment. That's usually best for any practice before they get bogged down in imaging or anything else. But usually I'll tell them if you don't like to wait, you can avoid a longer wait by getting a very, very early appointment. So tell them about that wait time because I have experienced this in the past, and I'm sure you have as well, where a patient went to their appointment and just left. They got tired of waiting. So tell them that. Plus, they're probably getting through so fast in your clinics, they already have that expectation that it'll be the same there, and it is not. In my last slide, I did say talk to your patient about treatment plans, but don't tell them this is what you're going to get. All right. So one of the things that a lot of doctors will do is if they see any macular edema, they'll tell the patient, well, you're going to get an injection. Well, I can tell you that every patient that has macular edema does not get an injection. Getting an injection depends on multiple factors. One is their vision status. One is their insurance status. So several different factors play into that. It is helpful to tell them you may get an injection, you may get some other type of treatment, or the doctor may opt to watch you very, very closely. So any one of those things can happen. So avoid telling them this is what's going to happen because many times a patient will go to the doctor, to the retina specialist and say, well, my doctor told me I'm getting an injection, so it's not really our call to make at that point. But definitely do tell them they have a chronic condition that requires continuous care because another miscommunication that often happens is that patients think that let's say they do get an injection and they're fine. Like one injection and they're done. For we have to tell them this is a chronic, they don't take systemically, they don't take one injection of insulin and they're fine. It's the same thing with the eyes. Because of this damage, this requires chronic care. So this is something that they will have to go back and be seen for multiple times, very importantly. Many times these patients show up with caregivers. Give some time to speak to the caregivers as well. Tell them about this condition. Tell them about the chronicity of it, that they'll have to be seen multiple times because at this point, this is someone who is commuting with them or commuting them, waiting along with them. So it's very important that they also be involved as well. And then one technique I do is I use, this is the teach back method because we all know patients do this notoriously. You're giving your patient education. They're nodding, right? Like, yeah, they get it. They understand. Okay. And then like, okay, tell me what I told you. And they can't remember anything. You said that I have cataract. Oh, no, that's not what we talked about. All right. So very, very importantly, have them say it back to you. I find that when they repeat it back, it really solidifies their understanding of it. So very importantly, it helps with kids and partners as well. Okay. Another thing that we notoriously do is when we refer a patient, bye, we'll see you when we see you, or we somehow hope or assume and again, it's no ill intention on the retina specialist point, that when the retina specialist is done with the treatment or has done it, that they will send them back to us, or the patient will know automatically. None of those things happen. Again, no matter also how close of a relationship you have with a retina specialist, because they don't make the appointment, their staff do, or things like that. So this is what I explicitly do with every single patient that I refer. I make sure that they have a follow-up appointment with me all the time for several reasons, which we're going to go through in a minute, but make sure that they have a follow-up appointment with you. This follow-up appointment ensures that you have another touch point with the patient. You have another opportunity to speak to the patient about their treatment, address any patient concerns or anxieties. And I can't tell you how often that I have scheduled a patient to come back, and I'm so glad that I did because either they missed the last appointment, they didn't, or the appointment that was made for them, and they didn't think to make another one, or they left or they got scared or whatever reason, but this kind of puts it back on their radar again. The other issue is that I find a lot is while the optic nerve is in the retina and the retina specialist may know that the patient's being treated, for example, for glaucoma, I can tell you a lot of retina specialists don't look at that. All this ophthalmology specialties, they sort of live in their own lane. So if you are, a lot of our patients, we also know these diseases our patients have multiple diseases. So uh, patients that are more inclined to be diabetic have a higher chance of glaucoma anyway. So make sure that you're still seeing those patients. Don't trust that their treatment's going to be continued with the referring doctor. You still need to see them back for anything else that you're treating them for. And then very importantly, as they're going through treatments or as their vision is changing, their vision needs are going to change. You need to address their refractive concerns or any corrections there. And then very importantly, if you uh, offer low vision services or if you have a colleague that does, making that appropriate referral as well so that patient can still continue to be a productive member of society and have functional vision as they're going through this. So patients getting treatment for retinal conditions, they're going to have a few pre-existing conditions that should still be managed. As I mentioned already, glaucoma, their refractive error, and the two that are really the very first one is probably one of the biggest ones. When these patients undergo treatment with a retina specialist, their entire anterior surface is wiped out. They're they have a lot of ocular surface issues. So when I say dry eye, if they even had a little bit of it before, they're going to have a lot of it after. And that oftentimes is going to affect how they feel and their vision status even more than the back of the eye. So continue seeing those patients for treating conditions that they may have pre-existing or they may acquire as a result of treatments with retina. Another thing is that if, for example, they are getting any type of surgery or an injection, you want to make sure that the ocular surface is doing well, but also you want to reduce any risk of any possible um, side effects, especially some of the more scarier ones. And one of the best ways to do that is to treat any type of lid disease. Treating patients with Demodex goes miles for how well they do. It significantly reduces secondary risk of other adverse events, particularly things like endophthalmitis, which is one of the most serious adverse events. So treating that, very, very important. And I can't tell you that how grateful the retina specialist is to you, because the moment you suspect any type of endophthalmitis, it's always a scary thing. So if we can eliminate or reduce the chance of that in any capacity, we absolutely should. So collaborative care, what is our role in it? Typically, you're still, think of yourself, you're still the primary eye care provider, have those baseline evaluations, make sure you do all the functional testing, fundus examination, any type of imaging, and then continue post-treatment, those same types of things. And with that, we're going to go into our first poll question.
Well, I had a poll question up and running. I did a surprise
Oh, you
one.
did.
I did a surprise one. It was,
Okay.
are you able to text your retinal specialist or my retinal
Oh, I love
specialist?
that.
And so I got, so people want to answer real quick. It's kind of surprise. We had a low response. It's not an announced one, but I will display the results. I think the trend is there. We have 46% that say yes and 54% that say, or 52. Now we're kind of getting the 50-50. And just showing, I had a patient today with an epiretinal membrane. I'll just put it up here on the camera, and our vitreomacular traction. But what I didn't like was it went all the way down to the photoreceptors and almost getting this macular hole. So I texted him and he said, "Yeah, send it over. We'll talk about doing a vitrectomy." So there you go. I did one for you today. So
Good
I mean,
job. Good
and
job.
that's interesting when you say that, if you need neurology, something like that, it's a 6 month wait. You call a retinal specialist, they always say the same thing. Yeah, send them over. Yeah, don't see anybody. And my retinal specialist in the practice, I don't know how he can go through clinic, because he must have his phone in his hand at all time, because if I text him, I expect to be texted back within like 1 or 2 minutes. It's crazy.
Yeah, they do jump back and forth between patients real quick, and in between they answer those texts. They do. I wonder the same thing. I know they have like 50 or more patients on their schedule. How do they have time to answer me so quick? They do.
So, Roy, I have your polling question up if you want to read it to the audience.
So the question is which of the following conditions is cited as the leading cause of preventable blindness preventable being the key, blindness in working age adults.
Is it age-related macular degeneration, retinal vein occlusion, diabetic retinopathy, or inherited retinal disorders? The polling question is open. People are answering it. Which of the following questions is cited as the leading cause of preventable blindness in working-aged adults? Joe, are there any questions in the chat box?
All right, let me take a look. The answer is no.
Okay.
Oh,
So, all right. So that's making it synchronous. We've already done another synchronous. We're at the polling with the retina specialist. Not seeing a lot of responses rolling in here, but we'll display the result. Remember, everyone, this is what makes it synchronous, those polling questions. And we have 9% saying AMD. No one went with vein occlusion. No one went with inherited retinal. Your winner at 91% is diabetic retinopathy.
very good. Very good. Excellent. All right. Are you ready for me to move forward?
Oh, absolutely. Yep.
Okay. I would love to hear what people think about the closed captioning. I saw this at a lecture I attended and I really enjoyed it. These days, it feels like I can't hear anything unless I see the written word. I'm not sure why, but I absorb it a lot better. And so I started incorporating that into my lectures as well. And so I would love to, if you want to throw up another surprise question in there, how do you feel about closed captioning? And I always make a joke that it also helps with everyone understand my Mississippi accent. So there's that.
Well, this is one of those polls that goes 50-50, if you know what I mean.
Oh, yeah. Okay. All right. So yeah, it can also be distracting, but okay, but it's also helpful. So let's look at some innovative therapies being tested for retinal diseases, and as far as in addition to some new ones as well. So photoreceptors, these generative, there's cell therapy. We're going to hear a lot about gene therapy, and then there's neuroprotection. And then we're going to hear this word called optogenetics. So looking at clinical trials, some stem cell therapy, let's start there. There's AMD, stem cell therapy for AMD, RP, and other neurodegenerative disorders. One of a few of the most exciting ones are with stem cells, where patients, this was a study out of the UK, I believe, were inserted with, had stem cell therapy at the level of the RPE, transplanted for dry AMD, and the patients were there was a woman in her 60s and a man in his 80s, and after they were monitored for over 12 months and reported improvements in their vision. They both went from not being able to read at all with glasses to reading 60 to 80 words per minute with the normal reading glasses. So a few of the challenges in clinical trials is recruiting patients, essentially. So recruiting and retention of patients. Let me ask you something. Have you ever talked to your patients about clinical trials? Has anyone ever, and I can say that it's not something that was ever in my radar. Uh, I knew they existed. I don't know why I never talked to patients about it. It was just sort of like you have this treatment and then um, or there's nothing, or you have this condition and there is nothing available for you. But clinical trials, if you just go to clinicaltrials.gov, there's for any condition, there is usually an active clinical trial. And one of the biggest issues is patient recruitment. How do most patients find out about clinical trials? Well, they're Googling this. So that's where actually most of them hear from it. Many of them don't even hear it from their physician. About 10% of patients hear about it from their physicians. I will say the one type of physician that's a little bit better about clinical trials are oncologists. So, and many patients, if they were asked about, would you, if you knew at the time of diagnosis, would you participate in a clinical trial? Over 85% said that they didn't know, but 75% said they would absolutely participate in a clinical trial if they knew about it. What's the benefit? Why would anyone want to do a clinical trial? Well, for one thing, it's free treatment. And the other really, really great thing about it is, yes, you're exploring something that's questionable and, there's a whole lot of things that go with it, but you are given the absolute best care. So everything visually, systemically is measured when you are a participant. You are receiving the best care. And then the icing on the top of all of that is you're usually getting paid to do it. There's incentive for patients to participate in clinical trials. They're paid to participate. Usually they can be paid for their transportation. If they need babysitting, dog sitting, all kinds of stuff is covered because it's so important to get more and more people into these trials. So what should we do as far as make sure that we're aware? Certainly if you have a retina practice, I don't know of any retina practice except maybe ones that aren't, maybe those that are solo practitioners, but most retina practices, and let me say this, especially those that are purchased by private equity, they have a big clinical trial program. They usually have a really big, why? Let me just tell you, there's a ton of money in clinical trials. The clinic itself gets a whole lot of money, and for each patient recruited, there's a ton. And this is why that I hope that if you work in a OD/MD practice and you work directly with a retina specialist, make sure that you're exploring avenues to where you could be on these studies as well, because certainly there's a huge monetary benefit to that or incentive to do so, but it's also really exciting to see these patients go through these clinical trials, see how they're done, see how and possible outcomes that a lot of when you participate in them, you can almost tell who has the placebo and who has the treatment. These clinical trials are getting better and better and better. The study designs are better. Endpoints are better, the molecules being tested are better, and a lot of that actually has to do with the advent of AI being able to identify better molecules and help design a better study. So refer those patients. A lot of your retina specialists, they'll have multiple studies. Be aware of what studies are happening in your area. And again, you can check clinicaltrials.gov for a lot of those things. I mentioned earlier benefits of participation for patients. They have access to new treatment. They can contribute to scientific knowledge and helping advance medical understanding and treatment options. And then they'll get the closest medical supervision that there is. So let's look at a few of these clinical trials. One that's we're going to lead up into it. So we mentioned earlier, diabetes and diabetic retinopathy is the leading cause of preventable blindness in patients and working age adults. So there's over 20 million individuals in the population that we expect to have some form of retinopathy within the next 5 years. Of patients with early diabetic retinopathy, less than 1% are treated due to the high treatment burden. But we know if you see a lot of diabetic patients, there's this slippery slope. Once the retinopathy starts, it's only a matter of time, even better controlled ones that will still continue to advance. And look at the age of these individuals, median age 45 to 50. Do you remember whenever you used to think like 40s were old or 50s were old? Now we know what old really is. it's not 45 or 50, especially if you're in good health. That is actually probably some of the best years of your life. And so to be dealing with this chronic condition can be quite the burden. So early treatment, very, very important. And I want to highlight this part right down here. Let's, can you see my, yes, you can. Let me actually use the other pointer. This is actually a very, there we are. So for patients, this is the risk of if a patient has moderate non-proliferative diabetic retinopathy, their risk of progression to proliferative disease is 44% in 5 years. If they have severe disease, within 5 years, their risk of going to proliferative disease is over 80%. What about macular edema, the main reason that they lose vision? Similar thing. So 45% within 5 years will have some form of macular edema, and then 62% will, if they have severe, will have macular edema. So how do we treat patients with diabetic retinopathy? What have we been doing? So in the past, we've had laser or vitrectomy. Currently, we have a lot of anti-VEGF therapies. There's combination treatments, steroids for those patients who are not responding to anti-VEGF. But there's got to be a better way. So there's new novel agents and new routes of administration that are being studied and that are available now. Laser treatments, there's different kinds, focal and grid, PRP, and the newest ones, the navigated laser systems, are probably some of the best that they can actually give a great laser treatment for patients. And so what is the difference? Why would one doctor, when do you use focal versus PRP? So focal is still useful if you have a localized leakage. So in this image that we see here, we see that this patient has a microaneurysm, and with the pocket of fluid, that aneurysm, and once that local one is lasered, that fluid goes away. So that works really, really well when we know what the source of the fluid is. It does not work very well when you've got edema all over the place and you don't know what is causing that. So imagine your pipe system. You don't know where that leak is coming from. You just don't want to hit focal lasers all over the place. So if you have diffuse edema, kind of like your piping in an irrigation system is leaking, something like focal laser won't work. Laser's not helpful, and that's when injections become super helpful. PRP, it works, it's effective, but it can certainly be overdone, as in patients like this. PRP, I still feel like it's very, very useful, particularly in a patient population that may not be as compliant with their follow-ups or their treatment. Sometimes getting peripheral PRP actually saves their vision substantially when they are prone to being lost to follow-up. But lasers, they do have complications. All right, so some of the immediate complications of lasers is you can have subsequent macular edema or choroidal effusion. Delayed complications, epiretinal membranes or subretinal fluid. You know, if you ever have a patient that may even have an old laser for like a retinal hole, that patient years later may develop an epiretinal membrane. And one thing about epiretinal membranes, a lot of times we see them show up in one eye and then they show up in the other. But in patients that have the laser, a lot of times they'll just stick with the one eye. And then sadly, you have the patients who have foveal burns. Those are sad cases. And some of them actually even develop secondary CNVs from laser. So laser has its own complications. It's not great. So what do a lot of retina specialists do? It's anti-VEGF. And I like this just because call it a nerd in me, but I kind of want to know, because when did anti-VEGF really become a thing? How long has it been around? It goes all the way back to, many, many years ago, but it really, really wasn't until, and I'm going to go to this one better, that we started getting these different therapies. Back in 2004, Macugen, it didn't last very long, all right? It was the first FDA approved one. And then shortly after that, Avastin came around. And then very shortly, or right about the same time, we had Lucentis, which is specific for the eye. All right. Remember Avastin, it was originally FDA approved for cancer treatment, and its off-label use has really, really changed how it's treated in retina. But Lucentis is truly the on-label for wet AMD and later on for other therapies. Same with Eylea, first anti-VEG, FDA approved for, and it has an extended duration of action. There's other ones that have come out since. Beovu, it came out and then it immediately got pulled back, but it's out again, but not many people really trust it. Vabysmo, God, I've seen so many commercials for Vabysmo. So many commercials, but so Vabysmo has come out. It was got dual approval when it came out, and then there's new delivery, new ways this medication is delivered. So I like to break them down into the OGs. This is the OGs, the Avastin, Lucentis, and Eylea. And then we have the newer ones, Beovu, which people don't really use, and then Vabysmo. Oh, by the way, there's a ton of biosimilars. I'm not even going to get into that, but there's a ton of biosimilars that are approved as well. But even though we have all this new treatment, we still hear about our retina specialists still using Avastin. Why? Joe or Greg, you want to tell me why? What do you think they're still using that when we have these great on-label drugs?
It's inexpensive and it does work.
There you go. Look at the money. Yeah. Look at that dosage cost. Yeah, I can tell you this one, very expensive, but it works fantastic. I really works good. And but Avastin, very, very affordable to use.
Let me
So,
explain to the audience what happened with Beovu is that
oh,
it's
go
a
ahead. Yes.
immunosuppressor, or it monkeys with the immune system like they all do, being an anti-VEGF. And it created interocular inflammations, and they were hoping that it was going to be part of the process and the purity process, but it wasn't. What they found is when they injected it into eyes, people had an antibody. Remember, these are monoclonal antibodies. If you look at the last three letters, it says MAB on, let's see, all of them other than Eylea. So they're all monoclonal antibodies. So people had an antibody for the antibody, and it created intraocular inflammations. So they had a test for the antibody before they can inject it. And that's kind of why it went away. And then the kicker is if you inject it into an eye and they don't have the antibody, their immune system can form the antibody. So as you mentioned, the retina specialists are busy, and that's why it kind of died its own death because it was I guess in a sense you'd call it an allergy, but people had an antibody for the antibody.
Right. So it's not one that you really trust.
I looked down for him.
Oh, and here is, I just wanted to show a video of an actual injection being done.
Up a little bit for me and look up towards me.
Head or just eye.
Just the eye.
Keep looking right there. All right, we'll get you all cleaned up, okay? I look down for him.
I'm gonna let it play one more
Look
time.
up at the ceiling.
Put your chin up a little bit for me and look up towards me.
Head or just eye.
Just the eye.
Keep looking right there. All right, we'll get you all cleaned up, okay? I look down for him.
Okay. I want to put that up there because it's very important just so, we have an idea. If you've never seen one done, just to sort of see it. A speculum is put on there. The surface is, um, made sure to be cleaned and then just wiped down and everything. And that last drop is put in before the drop is done. It's very quick. The patient actually doesn't feel any pain, but the anxiety is certainly, you know, I guess what's really scary. I mean, tell me, did anyone else grow up hearing cross my heart, hope to die, stick a needle in my eye? Anyone else?
Of course.
And so, and so I guess so now we're asking to stick a needle in the eye. So it does give people a little bit of pause. Other things that give patients pause is the possible side effects. The most common side effect that patients get is, maybe injection site pain. You hear this, might get a little conjunctival hemorrhage. They'll see some floaters. I think a lot of our hours call is mainly those three things. The most serious thing that is very, very concerning is certainly endophthalmitis. The moment that that's seen, that's very, very concerning. And then, of course, as I mentioned, there's other things that can happen, retinal detachment, traumatic cataract. So I have a colleague who also lectures quite a bit in retina. And when you see an injection being done like that, it doesn't seem like it's that difficult. Uh, it certainly seems, and I'm not going to talk about scope or anything, but the issue here is if that's something that, she was saying that that's something we could absolutely do. Okay, it's not that difficult, but are you really also willing to deal with all the adverse events as well? So you got to take all of that into consideration. All right, so another so the protocols, how are these protocols done? This is very, very important where when we talk about with patients coming, it's not a one-time treatment. There's nothing that's a one-time treatment anymore. Very few things are. So they have to get constantly treated. And how they get treated differs really based on clinical practice, vision status, how the patient is responding. A lot of patients get a lot of initial loading injections. We call that a loading dose, and then they'll maintain it every 4 to 6 weeks. A lot of doctors you'll see also treat and extend, so they'll extend the interval every 2 weeks after treating it, but never really going past 12 to 16 weeks, and then reduce more. And, we do also have those patients who don't, we say it's chronic, but it's not really, really forever. Eventually, patients respond if they are controlling other factors. Of course, for each disease it differs, that they will respond in, but it does take several years often, whether it be for a wet AMD or for diabetic macular edema. And then there's some patients that receive it for an as-needed protocol. So kind of what are the specific indications and response rates? So for neovascular AMD, it's the first line treatment is anti-VEGF. A lot of these patients will maintain that same level of vision, and this is why it's very, very important to catch them when they convert to wet AMD. And fortunately, about 30 to 40% of them also have an improvement in vision. For diabetic macular edema, first line treatment is also anti-VEGF, and many of them have a vision improvement, and 30 to 40% have a complete resolution. Retinal vein occlusions, even better, absolutely even better. So although we want patients to see better, and this is a very, very important point, I really, really want to hone in on this. Patients should never go into the retina specialist thinking that their vision is going to get better. If they're lucky, it will get better. Make it clear to them that the point of treatment is that their vision doesn't get worse. Because I can tell you one of the very, very, very top reasons When I see patients back, because I made that follow-up appointment and I keep making those follow-up appointments for them, when I will see that they have missed their appointment with the retina specialist, and I'll mention it, and I say, why did you miss it? And they obviously have some areas that still need treatment, and they will say, because I wasn't getting any better. I wasn't seeing any better. Again, you have to remind them that the goal of treatment with injections, with laser, any of those things is that they don't get worse. The goal is stabilization. So remember that. So with that, can we go to our second poll question?
I did your closed captioning question. I said yes, like it. No, did not like it. So if you haven't answered the question out there, people, go ahead and answer. The trend has been set, it looks like. We got 78% who like it and 22% that say, I do not like it. So there's the percentage. We're 80-20. So there you go.
Oh, good.
Not everyone replied. It's probably about a third of the audience, but it's probably the trend. They're weighing in now. More people are coming in. Still holding the trend as it rolls in. So, all right. So 81, 80-20. There you go. Looks like it's a pretty good amount now. So stop, close, close. All right, let's see. So this one is now poll 2, I believe, and poll 2 is now number 3. So let's see. Yes. Okay, we're going to open up a new polling question. Go ahead and read that for us.
Which of the following is listed as a serious ocular adverse event, although be it less than 1%, to monitor for following anti-VEGF injections? Is it A, conjunctival hemorrhage, B, vitreous floater, C, stroke, or D, endophthalmitis?
And there are no
Joe?
questions. We're good.
Perfect. All right, looks like the trend is well set on this one. I think everyone's paying attention here, but we have 3% going with conjunctival hemorrhage. I'm not sure if that's a serious adverse event. No one went for vitreous floaters. Stroke, 1% would be a little high on that, but 2%, but 95% went with endophthalmitis. So
Excellent. Great audience. All right. So we were talking about anti-VEGF treatments. This is several studies that have been done about different therapies and how effective it is. But it does work. So here's a patient at baseline. You see they have this diffuse edema. 1 week after, they do great. Look at that. 1 month after, worse than they started. So it's effective, but it's not durable. So this is why they constantly have this chronicity. Not only that, they require multiple injections, but when the fluid does start absorbing, I always like to show this. This is another big reason patients drop out. All right. So earlier I said, patients said, my vision isn't getting any better, right? That's why they quit. And the goal was stabilization, not that their vision gets better. Well, what about the patient that comes back and says, my vision got worse? But you look at their OCT scan here and you're like, no, it didn't, because, I can see that foveal contour coming out, and like you show them, like you're actually getting better. Why is this patient getting worse? Well, this all goes back to optics. Remember optics? So light comes down this way. And so when this patient has even this diffuse edema, this light can actually penetrate through and get to the level of the RPE. So that patient has some vision. But when that fluid absorbs up and turns into exudates, remember exudates are a sign of chronicity as well. And during this time, you see how we have this hypotransmission defect here? Light isn't getting through. So this is why the patient is not seeing better, although they are actually getting better. All right, so this is where, again, it's very important that they see you again and you explain this to them because they're like, I was getting all these injections and I was actually getting worse. You told me at least I'd stay the same, you're getting worse. So this is another thing to be mindful of and tell your patients that this will improve. The key is we have improved the actual structure, the foundational structure of their macula here. So then you just have this other word that we have, this injection fatigue. And why is that? You have this patient that's coming in, has this injection every month. And then right here, we see this patient, okay, it's doing good. You're not going to get any injection. They come back in 2 weeks, look at that. If you ever get a grayscale, it's gone past red at this point. So you treat them again. Okay, you're doing good. They come back. You decide to observe. And look what happens. So it's really tough because these have to keep coming back. The frequency is different. Sometimes they get an injection, sometimes they don't. Patients are fatigued. Remember that wait time. And then you always have to have those side effects as well. So these other studies, this is why they essentially said that in addition to having injections, it also helps to have some laser done as well. They also showed patients that have severe NPDR, which is not traditionally treated with anti-VEGF, if they should also be considered for therapy because they also had reversal as well. So the paradigm is also shifting where before patients only with proliferative disease or diabetic macular edema were being treated, but now patients with severe disease are being looked at to be treated as well because they are also doing much better once they initiate that injection therapy. So you have patients here that gets treated, does better, but then it's lost the follow-up and then returns, and then the disease is even worse, and they have to continually keep getting injections. So I mentioned this earlier. If you have a patient that's prone to getting lost, and like if you see this patient right here, that should have told us right then and there what that patient should have had, especially if they get lost. That's a patient that needs combination therapy. So this is patients that will have that laser and anti-VEGF therapy. These patients won't have to get injections as often, and they actually do better anatomically with their anatomic outcomes. What about patients that get steroids? Who gets a steroid? How does the retina specialist decide about a steroid? Because we certainly have side effects with those as well. This is a patient who doesn't respond to anti-VEGF therapy. They're the ones that will do much better with a steroid treatment. Steroid treatments also are better because they have a longer treatment interval. So for most cases, the best course is really to have the best course of treatment is for patients with proliferative disease is to have a combination therapy. Injection alone is not sufficient, and not to mention that how often they have to get these treatments. I mentioned this earlier. All the treatment approaches that we currently have, they have fatigue. The adherence is not good. They have these side effects. So there's got to be a better way because it feels like we have been dealing with this for a while. And there's new therapies coming along. This is one by Ocular Therapeutics that is very promising. This is actually a treatment that it's anti-VEGF that will act on the extracellular side, and it binds to selective ligands like VEGF-A, and it prevents basically this pro-angiogenic activity. So it acts like it got an injection. These are much longer lasting therapies, and they can be extended all the way from 9 to 12 months with one sustained treatment that's basically inserted right here, and redosing is about every 6 to 12 months. Gene therapy. This is probably one of the most exciting areas of treatment, and we've long thought of it for inherited retinal diseases, but it's being looked at for other therapies as well. So Luxturna, it is the first FDA-approved gene therapy. And when I say how exciting that is, if you think about, and it's not just in the eye, it's considering all body systems. That is the first FDA-approved gene therapy that was out there. And it's done by an adenovirus, and which a lot of gene therapies are done that way. And we're going to go into a little bit further about how those therapies are done and how to identify those patients. So how is gene therapy provided? There's 3 different injection modalities: intravitreal, subretinal, and suprachoroidal. And each has its benefits and drawbacks. Intravitreal is like the video that we saw earlier. This is basically, it delivers right into the vitreous space. That's this needle right here, if anyone's looking. It's less effective for gene therapy to deliver the gene to the level of the RPE. And then, of course, it has other drawbacks as well. The best part of intravitreal therapy is that it can be done right in the office, right in the office. Subretinal, this is a very promising modality. It goes in the level right over here. You see this long needle right here? That's subretinal. It goes into the immune privileged space, so there's a low risk of inflammation, but it does have to be done in the operating room. That's one of the drawbacks of it. And then there's also other risk of cataract, retinal detachment, so many different things. And then there is suprachoroidal. This is one of the newest ones. This basically is also targeted therapy, and it increases that bioavailability in the posterior pole, and it delivers the medication into the potential space between the choroid and the sclera. So it's an office procedure, but anytime, just like when we learn something new, we have to go back and get CE and go to a workshop and learn for it. Same is true for our ophthalmology colleagues. When there's a new treatment, they have to go back and learn how to provide these treatments. So I went earlier, we talked about gene therapy. What if there was a one-time gene therapy that could provide long-lasting improvement for diabetic retinopathy and reduce the risk of that? And so this is a very, very exciting therapy. I've referred a few patients for this. This is by Regenix Bio, which is also part of AbbVie. And it's a one-time treatment, which is sort of surprising because if I was a pharmaceutical company, I want a returning customer, right? I want to keep making that money. But this is a one-time therapy, so I imagine it's going to be pretty expensive when it's available. But it's an anti-VEGF gene therapy that basically reduces the risk of progression to severe retinal proliferative disease. And it's given suprachoroidally. And it basically goes in, it has an FDA indication, and I believe I think it's done with, I know at our site, it's already done with patient recruitment, and the study is moving forward, but very, very exciting one to be on the lookout for. So we may no longer be telling our patients you're going to be receiving multiple treatments. They may just qualify for just one treatment. All right, and with that, can we go into our next poll question?
We certainly can. So number 3 is number 4, actually. So let's launch that.
And we're good on questions.
Polling question is open, so if you want to read it.
Okay, so the first FDA-approved gene therapy, Luxturna, is used to treat what condition? Age-related macular degeneration, diabetic macular edema, Leber's congenital amaurosis, or retinitis pigmentosa?
And we have no new questions come in, so we're good.
Wow, great audience. Either
Looks
that or people are off to bed early with this time change. I'm not sure. All right, you let me know when you're ready for me to move forward.
Yeah, they're rolling in. I think we got
Okay,
a
good.
pretty good amount.
Yes.
They're going to have to teach a little bit on this one because we have 20% or 19% now saying AMD. We have 28% going with diabetic macular edema. The winner is 41% with Leber's congenital amaurosis caused by RPE65 gene mutation, and 13% going with retinitis pigmentosa. So C is your winner at 41%. A and B are split at about 21 and 26, and not retinitis pigmentosa at 12.
Okay. This is for anyone who's ever taken a test. And Joe, you can tell me if this happens with you, but when I used to write test questions, because I had to write these somehow, and someone told me this, and I try to veer away from it, but it always happens. The longest answer is always the right answer. So not, if you are really stuck, you don't know what it is, try to pick the lengthiest one. And so I don't know if students have figured that out, but I try to veer away from it when I was faculty. And Joe, you have to tell me if you had that same issue when you wrote questions for students.
I think that was probably correct. I never really thought about it. If you look at the longest one, but we had a few test writing seminars, and I actually learned a few things about them. How a person who doesn't know anything about the topic can actually answer questions correctly, just by how the distractors are set up.
Yes, yes, exactly, exactly. All right. So we mentioned earlier we had some issues with how long these injections have to be done. But there's a new port delivery system for retinal diseases. So this is not treatment, but how treatment is delivered. So this is essentially as you can see here, a little device right here that's filled with medication. And so far it was approved for wet AMD. And it's put in right there, and it has sort of a sustained release type of thing. So this was approved, sustained drug delivery. It maintains drug levels for 6 months, ensuring, which is good. Again, this takes away, especially for wet AMD patients, these are going to be your older patients. It takes away the burden of coming in, waiting, or not being able to come in, all those things. For the retina specialist, they had to go back and actually learn how to insert this. And then what do you do once the medication is finished? There's actually a process where they have to take that out and refill it with medication. And offer it, put it in again. So there is a whole, process to that as well. So, we've been talking about treatments and injections and stuff, but I don't want to get an injection. I really don't. There's definitely got to be a better way. And there is. There's new ways. So we've been talking about injections. I'm going to call that the past or currently what's mostly available. But what's in clinical trials right now is so exciting. There are oral medications that are being in clinical trials. There are eye drops that are in clinical trials that, by the way, are doing very, very well. They're not all indicated for proliferative disease or macular edema, but they are, the ones here are also recommended for non-proliferative disease. More importantly, think about our profession. What does that mean for our profession? I said earlier, while injections seem simple enough, it's not something I necessarily want to take the risk on, but who can administer, who does eye drops better than us? And of course, oral medications as well. So when we talk about these new medications and these new therapies, it's important to be aware of them because it's really going to change how we practice in the future, how we're managing these patients and everything. So I want to shift gears to macular degeneration. I mentioned earlier that it is the leading cause of blindness in older Americans. There's different classifications. We still classify it based on the Beckman style. We manage it different ways, depending on what type of macular degeneration you have, whether you have dry or you have wet. What type of treatments is offered and what type of treatments used to be offered and what's available now. Before I get into treatments, I want to do a quick pivot to genetic testing. So who's had a patient come in and say, I took that 23andMe test and it said I could get AMD or I have AMD? I've had a few. And what's so interesting is they're all like 30 or 40, they're very young, which, what are we going to tell a patient that's so young? Obviously, they don't have macular degeneration, but I love that they're already getting involved in their care. And when I mention genetics, I have a different level of excitement. I just love genetics, genetic testing, because it just shows so many things. With AMD, it's not super helpful because AMD is not a monogenic disorder. There's over 40 genes. Some other studies say even more, up to 70 genes and alleles that the AMD gene could show up on. So there's multiple companies available that do genetic testing for it. It's not considered standard of care right now if you have a patient that you suspect might have AMD to have them do any type of genetic testing. That being said, there are companies that offer it. Arctic Medical, Nycox. This one is one that has been showing up a little bit more in our space. This one's called Visible Genomics. And what I like about this one is it's direct to consumer. It can be direct to consumer, or it can be something that you offer in your office. So it can identify for patients that don't have AMD, it can identify if they have any risk of it. For patients that do have AMD, it also can identify how likely it would be that they would progress. So it's very, very useful depending on however you want to use it. And like I said, there's different tests. If you want to purchase it, just like Arctic Medical and the others, I think Arctic Medical is one thing that they do differently is they also link it up to supplements, appropriate supplements. Some of the companies do that. And I apologize if I'm forgetting some other companies. I know a few more are out there. But if I can say that, and I know I've said this a few times tonight, if this was a drinking game, I don't know how many times you would have drunk tonight, but what I'm excited about, again, I'm always excited anytime we can offer patients treatment. Anytime we can offer patients treatments. And what have we been able to offer our patients with early and intermediate AMD? Nothing really. I mean, we tell them not to smoke, to have a Mediterranean diet, control other vascular conditions. But you're going to start hearing this word a lot. We've heard different versions of it, red light therapy and things like that. But this electrical impulse therapy or photobiomodulation, it's commonly referred to as microcurrent stimulation. It's a treatment that has been FDA approved for dry AMD. So this is what it looks like. They've had several successful clinical trials. They were FDA approved for dry AMD back a year ago. Wow. And I say that surprisingly because after FDA approval, it's been the practices that have them have just had them a few months. They went to a little bit. They were owned by one company. They were acquired by Alcon, so kind of a different type of. So it was a little bit of delay after FDA approval. By the way, it also even came with the CPT code as well. So it's the first FDA authorized therapy for patients with dry AMD to improve vision. It's available in Europe and other countries, and it's non-invasive light therapy for patients. So it has actually been shown to improve the size of drusen, and we're going to look at it in just a second, in these patients that have it. And this is what the unit looks like. It's not a very big unit or anything like that. It has it's about a total of 15-minute treatment. All right. It's done in the office. So what the patient needs is a course of 9 treatments. There's no dilation required, none of that. So it's 9 treatments with this, and it's done over 3 or 4 weeks. And it's recommended that these patients get these 2 or 3 cycles of this treatment. So I said there's a CPT code, but is insurance really paying for this? I don't know the information on that. The offices that do have it, patients are paying out of pocket for it, and they're happy to do so because it works so well. So it's not a laser. Let me be very clear. It's the eye, remember, our eye is the only internal organ that's directly exposed to the world. Everything else is covered up by skin. So when they talk about photobiomodulation, our eyes are a perfect place that can receive that great treatment for it. There's no tissue or bone or anything impeding the view in there. So it doesn't, deliver thermal treatment or produce any type of cellular damage. There's no phototoxicity, nothing like that. And then, of course, very importantly, there's no dilation required. So I want to show this, the results of this, and I'd like the scan because a picture's worth 1,000 words, right? So this was a reduction in drusen volume after 13 months without progressive retinal degeneration following this photobiomodulation treatment. So this was a female patient, 77 years old, her baseline acuity. And in clinical trials, there's something called BCV, so best corrected visual acuity, and it's measured by letters. All right, that's how specific it is. So that's where she was at baseline. After 13 months, she was at 79. At 24 months, she was at 80. That doesn't seem like a lot, but if we actually look over to her structural changes, that is significant. And if we think about patients with AMD, how long, or intermediate AMD as this patient had right here, how long before they convert to advanced disease? It's within 2 years. So this patient's doing much better. let's compare that to a patient who did not receive the treatment. So this is a male patient. He's younger, actually, 73. And he started out, let's see, yeah, he started out with a little bit fewer letters, 72 letters. And after 13 months, he got worse. And at 16 months, he turned wet. All right. So very, very important. So very exciting. And guess who can offer this treatment in their offices? We can. All right. With that, can we go to our next poll question?
Yeah, before I launch that, go back two
sure.
slides if you would. And
Tell me where you want me to stop, here or more.
go forward. Forward. This one here, when you were showing the drusen load on the B scan OCT, if you look over at the retinal pigmented epithelium thickness, you could see the drusen load there has significantly decreased. That's the white spots versus the orange stuff that's there. So you're looking at the drusen load decreasing in those pictures. And if you go to the next one, you'll see that it actually did worsen quite a bit. So this is actually kind of cool. Joe and I just did a live meeting in Detroit, and one of the key themes that kept coming out, because I was lecturing, Joe was lecturing, Jessica Steen was lecturing, was when it comes to chronic disease, we try to make things acute. Or when it comes to acute disease, we can make things kind of linear and kind of protocol. But when it comes to chronic disease, we can't really be linear. It has to be a strategy. So this is great evidence-based medicine showing how photobiomodulation works. It's red light therapy. It's going in, depending on the wavelength, kind of speeding up the mitochondria, increasing blood flow. There's a lot of science behind this. So we know mitochondria is important. We know blood flow is important. But is this going to be the only, talking to the audience out here, is this going to be the only thing that we do? No, this is part of a strategy, right? So we want the patient to go out and exercise. It doesn't mean they have to join Planet Fitness. They can go and walk, and they can maybe lift weights and take care of part of that, sedentary lifestyle. We got to teach them how to sleep. That's your parasympathetic system. Sympathetic is working out. We can teach them how to eat. We can give them good nutritional supplements. We can do photobiomodulation. So it's going to get really exciting here in the next few years about taking these patients and maybe lifestyle modification, nutrition, supplements, and using photobiomodulation like this. So really, really exciting there. But you can see it in the drusen load there, those maps about how this is. But couple this with a few other strategic lifestyle changes, man, it's going to be pretty exciting, I think, in the next few years. All right. So with that said, let me see if I can find the polling question where I ended up putting it, because I wanted to see that slide a little closer, and we'll get your polling question launched here. So let's see. This is 4 is now 5. So let's jump down here and we'll open the poll. All right, your polling question is open.
And we have no questions in here.
All right, so the question is, the Valeda light delivery system is a new FDA authorized therapy for dry AMD. What is the mechanism of this treatment? Answers are A, it is a conventional laser treatment. B, it is an anti-VEGF injection. C, it uses electrical currents. Or D, it delivers eye-safe photobiomodulation treatment using LEDs.
Well, it looks like the majority's on top of this. Looks like the trend has been set, and I'll display. No one went with laser. No one went with an anti-VEGF. We have 14%. It uses electrical currents, microcurrent stimulation. That would be like a TENS unit. That was out there at one point,
Yeah.
maybe still being used. That was 14%, but it delivers safe photo biomodulation treatments with LEDs. This would be the correct answer, D. And that
Very
was 84%.
excellent, excellent audience. I do want to say one thing. I was at a meeting and I was speaking about this. I don't know if you've had a similar experience. And I had an audience member, another physician who said, "Oh, I'm offering red light therapy in my clinic for these patients." And I paused because if this person was, they were probably one of the first at the time that I knew would had this system. I said, "No, it's not this system. It's something else this person purchased or anything like that." Here's the thing. Remember, this is the first and only FDA approved device for this indication. If you are offering it in your clinic under that guise, that is not right. I don't know how else to say it, but so just be wary of that. There's a lot of uh, companies out there, that will make claims and things like that, but you really need to ask these questions. Is this the FDA authorized device for it before you can make that claim to your patient? Okay. All right. All right, so geographic atrophy. Hopefully you've heard a lot about this within the past few years. I think since the treatment for this has come up, it has been significant education coming into our space. This was a patient population before. Whenever you would say you tell a patient they have AMD, and we used to say, "Oh, you have the good kind, the dry kind where you don't lose vision." But is it really the good kind if there's no treatment for it? So because we would see these GA patients just continue to get worse and worse and worse. Whereas someone who had wet macular degeneration, if it was caught early and they got treated, they got better, and oftentimes their vision got better. Granted, they had to get some injections, but we were able to salvage their vision, whereas we saw that these patients just sort of lost a significant amount of vision and there was not much that we could do. So a lot of the symptoms, I'm not going to go into the depth of these that we've know about AMD, metamorphopsia. I'm actually pretty impressed how many patients will immediately talk about dark adaptation before I even see the signs of AMD. And you'll know it a lot of times too. It's that patient that, you turn off the lights or in your exam room and it takes them a minute, or you take them from behind the slit lamp and they need a little bit extra time before their RPE essentially recovers and can see again. So those are oftentimes telltale signs that before you even see anything. And of course, there's devices to check that as well. So there's potential therapeutic therapies for GA, many of them being, gene therapy, as I mentioned, but the one that has gotten a lot of attention and has gotten approved is the complement therapy. So this is, if you remember this back from school, this was your complement cascade. Who remembers that? Not me, but it is important whenever you're actually looking at this drug, because the two that have been approved work at different levels at this complement cascade. What does this mean for our practices? It means that we actually have to get better at identifying this early and getting our patients in for treatment. So the two treatments now right here, one works at this level right here at C3, which is Syfovre, and then there's Izervay, which works at the C5 level. Again, when first released, there was initially some issues. Syfovre was released. I don't know, Greg, if you want to give us that background again. So initially there was a little bit of fear in this, but I think it's moving along nicely since that time.
Let me just go back to that, and I just want to make an explanation to the audience here is that remember that we have an innate immune system, we have an adaptive immune system, then we have the complement immune system. And what we're looking at here is the complement system. If you remember everyone out there, this is the membrane attack complex. It makes like the little straws. It can plug into the bacteria and viruses and cause them to explode. This is what you want. And if you look at genetic testing, you'll see that there's the people have genetic SNPs in that are risk for macular degeneration in their arms, in their complement factor H, in their C3, in their C5. What's remember, this is the immune system. When your immune system activates, it turns on, and then your immune system then turns off. When you have a C3 or C5 SNP, that means your immune system cannot turn off properly. And that's what the issue is in macular degeneration and in dry geographic or in geographic atrophy. Is that you have a genetic SNP, a C5, a C3, your immune system turns on, it can't turn off, and especially in macular degeneration where these SNPs are found in the RPE, then it destroys the RPE. That's your geographic atrophy, and the RPE is the life support of the photoreceptor. So the key here is that these medications are kind of inhibiting the C3, the C5, because your immune system is kind of broken and can't turn off. And that's how these medications come around. So remember, this is normal immune system, but when there's SNPs, they can't turn off, causing retinal RPE destruction. And that's why these medications target this, whether it's the Izervay or the Synvovry by Apellis and Astellas. So that's kind of teeing it up for you.
So one of the ways I actually like to describe that is if you've ever had a vacuum cleaner that like sucked up like a whole bunch of the rug, like just ate it up like it wasn't supposed to. That's essentially what's happening, and that's what these medications will stop doing. So kind of putting it in layman's terms in that. So this are some of the studies that were done, the Gather study, as well as for Apellis and for Astellas. And it showed that patients receiving the injection significantly over time reduced those GA lesions anywhere from 20 to 30%. I think different studies have different numbers. So again, it's one of those things. This one, I would say one of the biggest difficulties with GA therapy is, unlike wet AMD, patients know their vision goes away very quickly. So they know, I don't want to call it the cell, but them essentially getting that therapy, there's usually not much resistance. With your geographic atrophy patients, there's a little bit more pause because their vision is getting worse, but it's not instantaneous. But as we have seen these patients, and I love this right here, if over 3 years, if left untreated, a patient that's 20/30 to 20/80 could progress on to 2100 to 2300. Our goal is that does not happen. We want that patient to, if they receive treatment, want to sort of keep them there, stop them from progression. So that's, and a lot of times also going back to working with retina specialists, we identify this, we may send our patient in for it, but what also helps the retina specialist, remember I said one of the things we should do is have baseline imaging and consecutive imaging each time we see these retina patients. So one of the ways that retina specialists need to start, helps them show the patient as well and initiate treatment is showing that these GA lesions are getting bigger or more numerous. And so if you can show progression, it's a great patient for treatment. What's on the horizon? Visual cycle modulators, gene therapy, that again, very, very exciting part because and we have seen this in all medications. You notice how some patients will respond very well to certain treatments, but other patients do not. What is it in that gene makeup that makes each patient respond differently? So identifying the genes and going specific gene therapies, that is kind of very exciting on the horizon. And then there's ones that don't pan out. Sadly, there's a few that have not. For wet AMD in the past, we had focal laser that we did a lot for these patients with this macular neovascularization. Again, you have a focal area, can stop that but you had permanent vision loss in that area. And then you had these kind of things that would show up. You do laser one area and you got a whole lot of damage around it. So we really need something that does a little bit better than that versus photodynamic therapy and focal laser. Anti-VEGF substantially did better. 43% of patients without it are legally blind within 3 years, but 90% maintain their vision, and many actually, as I mentioned, get much, much better. So here we are, these patients that get multiple injections, they get better, they get worse. You have to have repeated applications. So a lot of times it's the same story as in with our diabetic patients. One of the things that we saw happen during COVID was these patients, again, many elderly, they were worried to come out. There was a lot of lapses in treatment. And these patients significantly did worse or converted without being caught. What do we use right now to tell our patients to monitor their vision? Amsler grid. Now, as much as I talk about patient education, I really cannot find a great way to tell patients how to do that test. It's a great chairside skill. I do use it chairside, but going home and doing that, it has just not been as valuable as other means. I have one here. There's a few others, like 4C Home, that is a service that you can prescribe for your patients. They send a device to your patient's home and it monitors their vision. It's not a home OCT. It uses a form of AI, maps their vision, and if there's any change in the vision, it alerts you, the doctor, to have the patient be seen. Why is that important? Because studies have shown that the sooner a patient is caught, the better their visual outcome, and treated, by the way, caught and treated, the better their visual outcome. And patients are caught much better with a home monitoring device versus traditional Amsler grid. Because, and then this is another study here that I wanted to show, that it shows that when these drugs are in clinical trials, they usually do really, really well because the doctors are sticking to a protocol, to a regimen. But in real practice, all of that changes. As I mentioned in the first slide, they kind of treat and extend, treat and watch. And so their outcomes are not as good. And this is actually comparing it by different countries, who's doing better and not so good. There is a home OCT available for wet AMD. And as we're coming to a close here, I think we have one last poll question, but there is a home OCT available. You may have not heard about it. It was approved not terribly long ago, but within the last year, a little bit, not quite, but it's being more directed towards retina specialists, but there it works similar to 4C Home. It's actually made by the same company. It communicates with a data center that sends the information for analysis and then alerts the doctor if anything has changed. And so, with that, I want to go to our final poll question.
Right, it will be open in 1 second. I have to decipher 5 is 2, so go ahead, it's open.
Very good. So for neovascular age-related macular degeneration treated with anti-VEGF injections, what is the primary goal of treatment? The primary goal of treatment.
So you had a question roll in into the chat box here, and I went and found one of my slides. It says, "What is the technical details about the Valeda? What is special about the spectrum?" If you want to take a crack at it, if not, I am building a device, and I started doing the research on this. If you want to take a crack, or I
I
can fill in.
I would say as long as you're ready, Greg, go for it.
So in my functional medicine studies over the years, when I go to the A4M meeting, which is in Vegas here in a few weeks, there's a ton of photobiomodulation that's out there. So Roya is correct. There's all kinds of devices that are being used within functional medicine for many different types of ailments. So the first thing you have to understand is that it's super confusing. I've been studying this and trying to figure it out, but it comes down to, you have to know the wavelength of the color of the light. There's red, there's near infrared, and there's penetration of the tissue depth based upon whether it's red light, near infrared, and then there's deep, muscle penetration, skin penetration, so on and so forth. Then you come down with irritants, which is your power. Then you have joules and you have energy. Then it's whether it's LED versus laser, the pulse versus continuous. I mean, it's very complicated when it comes down to it. So now the specifics of the Valeda biomodulation, what I have found by talking to them, and this is certainly not comprehensive, but I know that they're really touting the 3 wavelengths that they're using. They're using red at 660, and this will improve the mitochondria oxidation. And then you have your near infrared, which is 850 nanometers. This is again getting into penetration. That's the choroidal layers, working in the retina, working on anti-inflammatory signaling. And then you have invisible near infrared. That's the 780. Those are your 3 targets. So red, 660, near infrared, 850. Then your invisible near infrared at 780. And all of these kind of working together, kind of this triple, kind of get to the deeper retina choroid, the mid retina, which are your supportive cells, and then your red light is getting to the mitochondria. So that's kind of the sum of what it's doing. But I'm going to tell you that it's not easy, it's complicated, and it's all about all those other things that we chatted about.
Yes, and you're right. And I love how you said that because this space is going to get even more, this landscape is going to get even busier. So how do you keep it kind of separate? When we talk about FDA, these companies set up clinical trials, a study, endpoints, measurable endpoints, and so where they can make certain claims. And us as physicians, when we are, also communicating that or offering that treatment, if anything happens or anything, there's that, certainly not, I don't want to say anything happens, but one of the biggest questions is going to be, were you using, what was this FDA approved for? What was this on label for? And so you never want to be caught with not having an answer to that. But I will tell you, when I speak to a lot of these companies too, there's lots of claims being made. It is important to do your due diligence and look up the information. As I always appreciate you do so much, Greg. I didn't realize that you got so much into the granular aspect of things until I started working with you in this capacity, and I appreciate that.
Yep, no problem. I didn't realize it's 9:54, so
Ah.
Yeah, we need to wrap it up.
let's end this
Right.
polling question, and I already think I have it shown. So let's see. Yep, I have it shown. So the answer that everyone went with was C, stabilization.
Thank
So
you. Great audience. Thank you, everyone.
all right, so I'm going to have you unshare if you would.
Thank you, Roy. It was very educational and the time did fly by.
Thanks.
All right, everyone, if you look at your screen, that was what alerted me to it, was the little red dot popped up. What you can see here is the little red dot. If you go right here, you could start that post-event survey. Again, we do need that for the regulatory boards to show that we are closing gaps. So please answer those polling question for us. I just did look at the questions. We're all wrapped up. So I want to thank everyone for attending Next Generation of Retinal Care, Emerging Therapies and Best Practices for Modern Co-Management. This was a synchronous virtual course. Roya, thanks for being here and delivering us this information for optometric education consultants.
Thank you. Always a pleasure.
Thanks so much, Roya.
Thanks.